I think a hygienist in a general dental practice can easily produce $500,000 plus using endoscopy, which is unheard of for hygienists, and that's why it's understandable why the doctors aren't able to pay their hygienists what they're asking for.
Hello, everybody, and welcome to another episode of the Raving Patients Podcast. Just a couple of quick announcements. Number one, I want to make sure everybody knows who our two sponsors are, the Doc Sites and Dental Intelligence. They are big supporters of my podcasting, allowing me to come to your inbox every single Friday at 6 a.m. Eastern Time when the episode's released. I also want to mention everybody about my event in Scottsdale, Arizona. It's coming up September 27th and 28th at the Scott Resort and Spa. It's called Supercharge Your Dental Practice. This is year number 2. We have 13 amazing speakers discussing the business, marketing, leadership side of dental practice. We have some financial stuff as well. So go check it out at superchargeyourdentalpractice.com and use the code RAVING, as in raving patients, to save $100 on registration. My guests are Kristen Ranaldo and Aziz Bohra, both with PerioView, and we're going to be talking about what dental endoscopy is and how you can implement it in your practice and how to make a whole lot more money with it. Kristen Ranaldo is a dental hygienist who graduated from Farmingdale State College in New York in 2015. She has 9 years of clinical experience, most of which have been in the periodontal practices as a surgical assistant. Dr. Aziz Bohra is a graduate of Marquette Dental School and a seasoned alum of the University of Louisville's periodontal residency program. Aziz has dedicated his career to advancing the treatment of periodontal disease. In 2013, he took a significant step forward by integrating dental endoscopy into his practice and then combining technologies like lasers and biologic modifiers with dental endoscopy, offering patients minimally invasive surgical options that prioritize their comfort and well-being. In 2022, his passion for innovation led him to establish PerioView, a company that enhanced dental endoscopy technology and has brought these updated or upgraded tools to the market, further elevating the standard of care in periodontal treatments. Kristen Ranaldo and Aziz Bohra, thank you guys for joining me today.
Thank you.
Thank you for having us.
So let's start off with a very simple question, which everybody wants to know about. And I had that for you when we first spoke about it, Kristen, is what is dental endoscopy and why should someone bring it into their practice, or why should a general dentist consider bringing it into the dental practice?
Dental endoscopy used to be known as a scaling and root planing alternative, but it's more a microsurgery. So the way that things are going now in dentistry, I do work in a periodontal practice, but DSOs are coming in and they're wanting to keep all the treatment in-house. And general dentists are wanting to do the same thing. So by incorporating dental endoscopy into your practice, and because you're getting surgical results with it, you're able to visualize subgingivally at 100 times magnification. So it replaces the need to do osseous surgery, because in the past we used to cut just for visualization. And with dental endoscopy, because we're able to see, the hygienist is able to treat advanced cases in-house. And the general dentist is then able to charge more than what they would charge for just blind scaling and root planing. And you get more predictable results that way. Also, while the hygienist is performing endoscopy, they are able to see things that you can't necessarily see on x-rays. So a lot of times I'll find decay at the crown margin, I'll see root fractures, gutta percha perforation, external root resorption, excess cement overhangs. So then that allows the dentist to find more treatment as well.
Got it. Aziz, anything to add to that?
I think Kristen covered it pretty well. I think one other thing I would add is a lot of times we have patients that are in restorative practices. They don't want to go anywhere else. So they don't end up, or you give them a referral, they don't end up going. This way they can stay in the practice, get the treatment done, and more restorative treatment if this needed after that as well.
Well, I think that in general, that's been the whole big push to have general dentists bring everything in-house rather than referring stuff out. Because look, I was the world's greatest general dentist because I knew what I enjoyed doing and what I didn't enjoy doing. And I referred out a lot of procedures I just didn't enjoy doing. So I didn't do periosurgery. I didn't do molar endo. I didn't take teeth out. I referred that to all the specialists the very difficult orthodontic cases I referred out. Okay. But I had so many patients who said, why can't you do it? I want to stay in the office here. And I think that's the preference sometimes, because the patient stays in-house, but you also don't lose the revenue. That's kind of an interesting take on things. So can you talk about what advancements have been made in the technology over the years? Because again, a lot of people are unfamiliar with exactly how it operates and what it can do and can't do.
First, dental endoscope came out in 1993.
It's an older technology, so.
Yeah. At that time, it was a dinosaur. It was massive. Yeah, and the image quality was pretty poor, as you can imagine. And so over the years, it's gone through a couple of different generations of it. And the last, before us coming into the marketplace, the last one, the big advance was made in 2008 with the Perioscope. And they had made, the image at that time was about it was a circular image, about 6 inches in diameter. And the resolution was about 10,000 pixels per square inch. The reason I got into it, my practice depends on this technology. We've been using it for over 10 years. And for the 15 years, it had no advancement had been made. And if you think about it, back to our TV, we had 720i, 720p. Now it's high def, now 4K, 3D TVs. I mean, we made huge improvements in image quality, but not in endoscopy. So about 2 years ago, we went in and we increased the magnification from 40x to 100x, and also the definition is high def, basically by 160,000 pixels per square inch, so 16 times more clear than that old technology.
Kristen, anything to add there as well?
Yeah, so our technology also, because it's a digital camera instead of a fiber optic like the old technology, you're able to take still images and record videos just like an iPhone of what you're seeing below the gum. So a lot of patients accept treatment because then they can actually see what you're seeing. And because, sometimes you'll do a debridement and they're like, oh, but my teeth feel clean. I don't have any supragingival calculus there. And then they will just stop treatment. But with this, you can show them. Same thing with a root fracture. Sometimes you can't show them a root fracture on a 2D X-ray or a 3D X-ray. So if you're able to show them that horizontal fracture, they're more accepting of treatment.
Now, Aziz, we had you had mentioned, or Kristen had mentioned to me in our introduction, you have a ton of referral doctors referring to you. So do you have more doctors referring this to you to do in the office? Do you also have a lot of doctors who you go in or someone else goes into the office to use as well? What's the best way for a general dentist who's listening to this to implement this in his practice? Is it he's not buying it on his own, I'm assuming, necessarily, or is the periodontist or the person doing it bringing it into the practice? So talk about the implementation into the office.
I think it's the equipment that you need to have in the office is not easily you can't transport it from one office to the other. It's easy to move it from operatory to operatory, but not offices. So you need to have it in your office. Most of in my practice, referral base, they refer the patient to us. And a lot of times the patient themselves, they talk to other patients and they go, hey, I need to have surgery done. We can do it minimally invasive. And they come in, through internal referrals.
Got it. So now, Kristen, you actually you actually understand how this operates. So can you talk about the best way for a dentist to implement this into his general dental practice?
Yeah, so you definitely need the hygienist and the doctor both on board when purchasing the unit because it is an investment, but then you also want the hygienist to use it. And for me, I always regretted not going to dental school, and this kind of filled my bucket of wanting to do surgeries or other procedures. So when you come out of school, you're kind of like thrown into that, just do prophies and perio maintenances all day. But I don't think doctors realize how much they can use their hygienist for. And in a general practice, it's a great opportunity to bring in that extra stream of revenue to then pay the hygienist more money because they're producing so much money. A lot of the conferences that we've gone to recently, the doctors who take insurance, whether it's perio or general, they're kind of breaking even or losing money on the hygienist because of there's a supply and demand of hygienists. So we're asking for a lot more money and the doctor just can't pay us. So not only would this allow the hygienist to produce more, they'd be able to make more money, and it helps to retain your hygienist because we always want the new innovative technology.
Got it. So what is the best way, or what are there's obviously a couple of models. One is you refer to the periodontist and the periodontist does the work. The other model is to buy the machine and then bring someone in to do the work for you.
Exactly. Yeah.
Can you just talk about the economics behind that so someone understands what does the machine cost? What do you typically charge for a procedure? Can you go over those economics so someone who's listening to this or watching this can say, well, this might be something I want to consider for my practice?
Yeah. So Aziz, do you want to touch on that since your practice takes insurance?
Yeah. So basically, if somebody's coming in, like first backing up, about 42% of the U.S. population has some sort of periodontal disease. So most of restorative practices, there's a lot of patients adult patients who have periodontal disease. So you already have those patients in your practice. And what we'll do when you purchase the endoscope is $42,000. And what we do is we will come into your practice and train your hygienist how to use it and implement it in their day-to-day use. It's a two-day live patient training. So we'll train the office in how to use it, and go from there. Most of the time, basically, if the patient has mild periodontal disease, you can do just basic scope and get it cleaned out. And the patient responds every time pretty predictably because all the calculus has been removed. In more advanced cases, you can still use an endoscope by itself, or you can combine it with other technologies like the laser or biological modifiers, up to your comfort level with those things.
Got it. And then if you're a fee-for-service practice versus an insurance practice, what are the economics on the reimbursement from the insurance company, or what do you charge a fee-for-service patient who doesn't have insurance, typically?
Okay, so fee-for-service, our normal fee is per quadrant. After the SRP fee, additional $400 per quadrant for using the dental endoscope. And it can vary region to region and city to city as well. So that's just for the scope by itself. And if you are combining with other technologies, then you can charge appropriately what you want to implement it with. So for a full mouth SRP case, you'll have an additional $1,600 in added revenue for that service.
Just to confirm, they are going to charge for the scaling and replane plus the use of the endoscope.
Yes.
And so if they're charging, let's just say $350 a quadrant for their scaling and replaning, that's $1,400. You're getting another $1,600. So you're basically doubling your revenue in the same amount of time.
Yeah, exactly. And in my practice, we're fee for service. We charge about $500 a quad for SRP, and we're tacking on an additional $800 to $1,000 per quad. And if the patient has insurance, we're still billing that scaling and replaning code just in case they could get some type of reimbursement. Fee-for-service practices have more of a flexibility, but regardless if it's insurance or fee-for-service, you're still adding on an additional cost because you're getting those surgical results and then you're retaining the patient, keeping them in-house, and you'll be able to do their perio maintenances after that.
And for insurance patients, the insurance won't reimburse for the scope, but the difference between blind SRP and the scope is night and day, and the need for surgical procedure after that is so minimal that patients do not bat an eye paying the difference because they don't want to get cut up.
How long does it take is it very technique sensitive? How long does it take to actually, buy it, to start using it in the practice, do you think?
Yeah, so once an office buys a unit, we typically ship it out right away. And then we'll schedule the training about a month later just so the practice is able to find patients. We do 2 days of hands-on training. So we see 4 total patients, and we like to do different quadrants. So the hygienist gets to practice different areas of the mouth. And then after that, they're ready to go. There's definitely a learning curve. It's a 2-hand, 2-foot technique. And you are looking up at the screen while you're working as opposed to in the patient's mouth. So it takes about 10 to 20 cases to really feel comfortable. My schedule, which most hygienists have, is an hour per quadrant for scaling and replaning. In the beginning, it might take them a little bit longer, but after that, it should just be an hour per quadrant.
Got it. So the economics are you're basically almost doubling potentially what you're bringing into the practice in an hour based on bringing this technology in. That's ultimately what the economics are.
So as a hygienist, I'm not producing less than $1,000 an hour. And then I'm also finding treatment as I'm working. As I'm going in there to remove the calculus, I find more treatment.
Got it. And can the general dentist use it for other things as well? Or what are the other things that you can do with it? So can you go over some of the other procedures that you can do with this type of technology?
Yeah, so you can also treat periimplantitis with it. When I talk to patients about this and I explain what an implant looks like, I say it looks like a screw, just a regular screw that would go into the wall. And if we go in there blindly, it's not likely that we're able to get in every single thread. So when I use the endoscope, I go thread by thread to remove cement, calculus, whatever is there. I've also had cases where there was an amalgam overhang and I just use my piezo to remove that. But because I can see, I know exactly how far to go. A lot of times with implants or restorations, I see cement often. And the gum tissue might not react to it right away, but down the road, it will eventually become inflamed. and root fractures, subgingival caries. So you can use it for a lot of diagnostic purposes. And if you do suspect something that you can't see on an x-ray or a cone beam, you can charge the patient a diagnostic code just to kind of see what's going on.
Got it. Aziz, anything to add on that?
This, again, for me, my practice, sometimes I get referred patients where the implant has failed and goes into the sinus and they shake their head, moves around. So once you open up this, and you take a cone beam, it's sitting in one place. When you go in, it's in a different place. So when you go in and open up the sinus, I've taken the scope and gone inside with the scope to find where the implant is and then kind of pick it out.
So I know we briefly touched on this, but Kristen, can you discuss or describe the revenue increase from the general dentist when they do something like this? I know, again, we discussed it briefly, but I was kind of describing things or asking you questions on that. Can you talk about that part of it? Because I think that's really important. Is everybody's looking to make more money, increase production, increase revenue being brought in. And this sounds like, yeah, look, it's an investment, $40,000+. But if you think about it, what you're charging, you don't have to do much dentistry to make that money back and more. So can you just discuss the revenue generation for the practice?
Yeah, so if a doctor is interested in implementing this technology into their office, we do have an ROI calculator, which will take their specific office fees, what they pay the hygienist and everything, and then we'll kind of figure out how long it takes them to pay it off. But whether it's a general dentist or a periodontist, it's typically paid off in a few months, and then it's just a revenue. So let's say they are charging $300 a quadrant for scaling and root planing. Depending on the demographic, you can add on $300 to that. You can add on $500 to that. And a lot of general dentists use adjuncts, whether it's Arrestin, subgingival irrigation. There's codes for that for insurance. But at the end of the day, no adjunct, even laser, same thing. No adjunct is going to work if all the calculus is not removed. So you're able to charge for scaling and root planing. You can add on that endoscopy fee. You can also combine it with Arrestin, subgingival irrigation, whatever that office typically does. And then using the endoscope is to ensure that all the calculus is removed. So then the patient doesn't need to be referred out, doesn't need retreatment. And then because they're charging that higher fee, they can pay their hygienist more. I mean, my production in my office is close to $1 million. Granted, that is a periodontal practice and we have high fees. But most hygienists don't produce anywhere near that. So then the doctor is able to pay them more and the hygienist is happy. It does help with retention as well.
I want you to repeat that one more time, because that's a really interesting figure, is that your annual revenue that you bring into or your annual production is close to $1 million. Okay. Now, again, you just said you work in a perio office, the fees are higher. But relay that based on the fees in your perio office, relay that to a fee in a general dental practice, just to give you, if you were working in a general dental office, how much would you think you'd be producing?
I think a hygienist in a general dental practice can easily produce $500,000 plus using endoscopy, which is unheard of for hygienists. And that's why it's understandable why the doctors aren't able to pay their hygienists what they're asking for.
Yeah, I think that's the biggest thing to take away here is, you're looking at ways to keep your hygienists around from looking for other positions. One way to do that is to pay them more money. This machine allows you to pay your hygienist more money. Yes, they're making more money for you, but then you also are basically paying them more money, which is what they wanted you to stay in the practice and not look for a job elsewhere.
Then I'm going to add one more thing. One thing is money aspect of it. Other thing, job satisfaction. If the job satisfaction is there, money becomes I don't want to say it's not important, but it becomes less of a deal. Because if you feel good about what you're doing and what services you're providing, and this is the office I can do that in and not the office next door, you're not going to leave. There's a value to that as well.
Yeah, I also think you're empowering hygienists. You're giving them more power than they would otherwise, because many people look at themselves as just tooth cleaners. And that's not what this does. This gives them a whole other side. It actually makes their job. Look, to be very frank with you, I did hygiene in dental school and it was boring. I could never do hygiene. I never enjoyed doing it. When I was a dentist and I had to do hygiene, if I was forced to, I was bored. And it would just be the same thing. Oh, yes, you love those patients who come in and they're covered in calculus. That's like what you pray for when you are a hygienist. But just doing the same, cleaning over and over again, it gets kind of boring. This gives them a whole different way to look at their career, and what they can offer to their patient base when patients come into their practice.
Exactly. And right now, there's only 1% of hygienists in the entire United States that use dental endoscopy. It's not taught in dental schools. It's really not taught in dental hygiene schools. And it should be the gold standard of care because for the past 50 years, the gold standard of care has been removing calculus. And for me, it makes me instrument differently. A lot of times when I'll go in there, you'll see the difficult spots and it's even hard to reach. Like when I came out of hygiene school, I didn't use my right and left tips. Now they're my best friend. It allows me to get into furcations, crown margins, at the CEJ, the distal line angles, those really difficult spots to reach, I'm able to perfectly see.
Got it. So anything else that you feel is important to let the viewing and listening audience know about dental endoscopy before we switch to our next section, which I call our Q&A, lightning round Q&A. But I wanted you to, the floor is yours for a minute or two if you wanted to discuss anything else regarding the technology.
My biggest thing is that our medical colleagues have been using endoscope for the last 20, 30 years. We have not adapted that to our field. I mean, I remember when I started in dental school, I had 2.0 loops. Now I'm at 4.5 loops. All of us, as we get older, we have bigger and bigger loops. We have the headlight. We've used microscope, but microscope is kind of limited. It has direct line of sight. So you still have to cut a flap or you have to be able to see it to get the magnification. This allows us to go below the gum without cutting the tissue. If I would never want to get osteosurgery because I know how brutal that is. And this is the way we can avoid cutting people up. So it's just natural to me. We have to evolve this way.
So I just have a quick follow-up on that. So what do you think the reason is that so few people are using it? Is simply brand awareness? People don't know it exists. They think it's too expensive. What do you think is a reason why, I think, Kristen, you always said 1% of hygienists use it or something like that. So what is the reason behind that, do you think?
I think one of the big reasons is the older technology that when it came out, the resolution wasn't as high. So it wasn't as user-friendly. By making high definition, you can see exactly what you're doing. So that makes it easier and the image is larger. So it makes it easier to see. Also, the market, I think the marketing was not done really well at all. And for the last 10 years, it wasn't marketed at all. It was Zest had it, but it sat there, didn't do anything.
Got it. Kristen, any final words from you before we switch to our Q&A?
I just want to empower hygienists to ask their bosses for modern technology that will not only help their patient care, but that will elevate your career and really take it to that next level.
Okay. All right, guys. So for those that are new to the podcast, we always get some new people. I do a lightning round Q&A. We're going to ask both Kristen and Aziz about 10 questions related to business and those types of things. And then your job, guys, is to answer this as quickly as you possible. I don't want long, drawn-out answers. So let me pull it up here. And let's start off here with the first question is, what have you read online recently that has inspired you?
I'm going to say that I just wrote my first magazine article in Denti magazine.
That's good. And Aziz, how about you?
I just read a lot of self-help books. So I go through a million self-help books on those things.
Okay, perfect. So Kristen, what deserves all your attention but seldom gets it?
My dogs.
Okay, nice. Aziz, you're in.
Right now, my practice, because I'm kind of divided up between two different businesses.
Got it. Okay. What is one thing that you will never give up on? Aziz, we'll start with you on that one.
Family and friends.
Kristen?
I would say my passion for dental endoscopy, and I'm going to continue to get the word out there about this technology.
Okay, this one's a tough question, and people get stumped on this all the time. So if you had to open up a lemonade stand tomorrow, what would you call your stand? Kristen, we'll start with you on that one.
Fresh squeeze.
Fresh squeeze. That was quick. That was right. That was really fast to get to with that. How about you, Aziz?
Quench your thirst.
Quench your thirst. You guys, those are two really good names. That was really good names. So, all right, let's see. Aziz, we'll start with you here. What is one skill or trait you feel is imperative to be successful?
Can't give up.
Kristen?
I would say being humble.
Being humble, okay. Do you have a favorite business podcast? And don't say raving patients.
I don't listen to a lot of podcasts.
Well, now you have to listen to yourself.
I always listen to A Tale of Two Hygienists.
Oh, okay. Yeah, with Andrew Johnson, someone else, right? Yeah, yep. All right. What is your greatest fear and how do you manage it?
I would say my greatest fear is not being good at things.
And how do you manage it?
I'm a perfectionist. I'm a dental hygienist with that type A personality. So I just drive myself crazy.
How about you, Aziz?
What's my greatest fear? I hate leaving things unfinished. I want to, wherever I start, I want to finish it. So I drive myself crazy. Again, I was going through dental school. It's good period. It's an 11-year college program. Just got to stick it out.
Okay. How do you capture ideas? Do you keep a notebook? Do you use voice memos?
I have a notebook and I use the notes section on my iPhone.
My notes section on my phone.
Do you make a to-do list every day, weekly, or when?
Daily.
Daily to-do list.
Weekly.
Weekly to-do list. Okay. Last question, and this one is an interesting one here, is if you had to give up either your apps on your phone, okay, or email, which would you give up?
Email.
You give up email, okay? And Aziz?
Apps on my phone.
Got it. All right, guys, how can people learn more about PerioView? And if they want to learn more about it, what's the best way to find the information out?
Yeah, so if you guys want to contact us, our personal PerioView Instagram is PerioView1, and you can send us a message there. My personal Instagram is the Subgingival Queen, and if you prefer email, my email is Kristen, Kristen, at perio-view.com.
The best way to get a hold of me would be my email is Aziz, A-Z-I-Z, at periodview.com. Or you can text me. My cell number is 623-570-8910.
Perfect. This was an awesome podcast. Thank you so much for sharing your expertise. It's something that I really didn't know about. Part of why I do this is not that I'm practicing anymore, but I learn about technology because I love technology. I think this is really cool technology. Hopefully, you guys, you thought so as well. If you did, please tell everybody about it. Tell them about PerioView. Have them reach out to PerioView. If you like the episode, again, share it, review us, like us, do everything you can to help promote the episodes. I want to thank the sponsors, both Dental Intelligence and the Doc Sites, for their support. And as I end every single one of my podcasts, remember, your reputation matters. Until the next episode, thank you so much, Kristen and Aziz, for joining me today, and we'll talk to everyone soon.
Thank you.